who are living. Oh,
Sorry about that. Go ahead.
No,
We
that's
like to
okay.
record these. Go ahead.
Okay,
Go.
that's fine. So I can start now.
Yes. Go.
As you know that at this moment, we have about 6.2 million people are living with Alzheimer's disease. And annual incidence about 500,000 per year. But the prevalence, the total number of people at this time is about 6.2 million. And to take care of these people, we have spent about $355 billion each year. And it is estimated that if no preventive and improved treatment modalities are developed, by 2050, the number of Alzheimer's people will be doubled, and expense to the society and to the country would be $1.1 trillion. So this is a real problem for us from a human point of view, as well as societal cost point of view. And as you can imagine, the family cost cannot be calculated. So in order to understand that, first we have to see what are the types of dementia is. Alzheimer's dementia is memory loss, as you all know. And so dementia is, in Alzheimer's disease, accounts for about 80% of dementia. Another 10% of dementia is caused by what we call is a vascular dementia. And then another is a Parkinson's dementia. And you will be surprised to know that 60 to 80% of people who suffer from Parkinson's disease eventually develop dementia. So dementia is a real problem for us, not only with respect to Alzheimer's disease, but also in respect to other diseases as well. And also another about 5 to 10% is from a family history that is because of the genetics of Alzheimer's disease. Mutation in genetics induces an early onset of Alzheimer's disease. And if you are carrying a familial history, then the risk of developing dementia becomes at the age of 35 to 45 years of age. So to understand dementia, first we have to know what are the risk factors. And for example, most of the risk factors include, for example, age. Advancing age is a risk factor. Gender, this is very interesting. The woman has a higher incidence, almost 1.5 times more dementia than men. And I will explain later on why this is the case. And third is the diet. Poor diet can increase. Poor diet is also very important. Poor environmental factors such as exposure to mercury, lead, they can also increase the risk of dementia. And poor lifestyle, for example, smoking. People who smoke a lot can increase. And now we know that survivors of COVID-19 have also now increased risk of developing dementia. In addition to that, electromagnetic field radiation or EMF radiation that we get from Wi-Fi and we can't avoid it. This is a part of an environmental toxin that also increases the risk of dementia. So you can see there is a lot of risk factor, and some risk factor we cannot avoid it. Some we can modify it. And the risk factor that we cannot modify is age, we cannot do anything. Gender, you can't do anything. And genetic mutation, we can't do anything. But rest of the things, we can do something about it. An interesting thing is that we have to know, in order to develop any strategy for prevention or treatment, we have to know what are the biochemical, cellular risk factors involved in, say, Alzheimer's disease. We will take Alzheimer's disease an example of dementia. And if you look at that, during last decades of research have identified many cellular and genetic factor that can increase the risk of disease, Alzheimer's disease. And a few of them, I'll give you example. For example, increased oxidative stress due to production of excessive amount of free radical. Also, increased chronic inflammation is involved. Third is the defect in mitochondrial function. As you know, energy is extremely important for brain function. And if there is a problem with mitochondrial function, that can increase the risk of dementia. In addition to that, we also have a increased defect of proteasome. And proteasome is the enzyme that destroy or that removes all the damaged protein, cellular debris. They clean up the cellular environment. That gets defective. We also see that the what we call the attrition and of the DNA material. And so this is a lot of things. And most importantly is the formation of beta amyloid. As you know, that people already accepted fact that beta amyloid is the central issue that causes Alzheimer's disease, excessive accumulation of beta amyloid. And if you have beta amyloid, then it forms what is called a beta amyloid plaque formation. And then in addition to that, plaque formations, and if you have a plaque formation outside the nerve cell, that becomes a constant source, a steady source of inflammation, because this is a foreign object as far as the cell is concerned, because they become very aggregated. Also, there is another protein called tau protein. The hyperphosphorylation of tau protein is also involved in the Alzheimer's disease. So these are the various things, and people have used these targets to develop a strategy to prevent or to improve the treatment of Alzheimer's disease. But after what we analyzed it, we felt that increased oxidative stress is the earliest signal, earliest damage, cell damage, that initiate all the subsequent damage that I mentioned, mitochondrial dysfunction, amyloid formation of beta amyloid protein. And so this is very important to remember it. And so, but when the oxidative damage of the cell is not totally healed or repaired, then chronic inflammation sets in motion. And when chronic inflammation occurs, it releases a pro-inflammatory cytokines, additional amount of free radicals, complement protein, whole bunch of other toxic chemicals that are very toxic to the nerve cell. And so you can see that this is, so we propose that's the idea that, and I have written a paper on this issue, and anybody who are interested in, I will be glad to provide one, that the increased oxidative stress, the initial event, and since it causes the chronic inflammation, which also releases free radicals. So these two are very linked. And so the question is that what you can do. And so we propose the idea that increased oxidative stress and chronic inflammation are central to the development and progression of Alzheimer's disease. How about the person who has for example, genetic disease, mutation in APP, amyloid precursor protein? It could be a genetic mutation in that protein. We also have a preselin-1 and preselin-2. There are another two protein, they have mutations. And mutation in this gene also increases the risk of dementia. And when you develop dementia, so right now, there is no effective preventive guideline. The guideline that has been provided by the federal government and Alzheimer's Association is that modification of diet. You use a good diet, balanced food, less calorie, less fat, your standard balanced diet, a lot of fruits, vegetables, but also avoid the exposure to environmental toxin. But sometimes we can avoid all these things. Don't smoke. For these guidelines are very interesting guideline and very important guideline, but human behavior are so complex that they don't follow it routinely. They may follow for 1 day or 2 days, and therefore, despite of the valuable recommendation made by the federal agency as well as the private, like Alzheimer's Association, the incidence of the prevalence as well as the incidence of Alzheimer's disease continue to increase, not only in this country, but also around the world. And so we have to develop another approach, which will be addition to what we are getting recommendation, which don't have any impact in decreasing the incidence or prevalence of Alzheimer's disease. And so the question is, what is there that we can do it? Since we know now, and there is extensive literature to support this, that increased oxidative stress and inflammation is the major player in initiating as well as in the progression of Alzheimer's disease. So the question is how we can reduce them at the same time. This is very important. How we can reduce increased oxidative stress and chronic inflammation. If we can reduce them, all the subsequent cellular damage that we mentioned will be also automatically reduced. And so people have tried to address this issue in the past. And since antioxidant reduces, it is well known, antioxidant reduces oxidative stress. And so the idea was, let us try antioxidant. And there have been a clinical study performed on antioxidant. For example, they tried vitamin E in Alzheimer's disease, as a single agent, and I will make a distinction between a single agent versus multiple. When they tried a single agents, not only in Alzheimer's disease, but in many other chronic diseases, it has failed to produce any expected benefit that researchers thought based on the animal study, because animal study gave a positive response in terms of reduces dementia or memory loss. But human study, it failed to do anything. It was zero effect. And this gave a bad name because they thought that the now antioxidant is no good or never tried for that. And here is the reason that why it failed. You have to understand that. Not only it failed, but in some cases, like you saw the result with beta carotene in a trial of the heavy smokers, there the incidence of cancer increased by 17%. And I will again tell you why this kind of result you have with a single antioxidant. First, our body has a multiple antioxidant, and they are distributed differently, not from one organ to another organ. Their level differs. Even within one cell, this distribution of multiple micronutrients are different. Some are more accumulated in the membrane, and some are more accumulated in mitochondria, some in it is even within the cell, the different amounts are distributed differently in various parts of the cells. So just to that, not only that, but when these Alzheimer's patients has a very high oxidative environment in the body. If you measure the level of oxidative stress in Alzheimer's patient or even early phase of the Alzheimer's patients, and also if you measure the marker of pro-inflammatory cytokines, they are all very elevated. So when you try to do with single antioxidant to reduce the oxidative stress and inflammation, it is not going to work. Why? Because single antioxidant, it is well known in research, in a high oxidative environment of Alzheimer's patient will be oxidized. And in that scenario, the administration of antioxidant like vitamin E, instead of acting as an antioxidant, will act as a pro-oxidant. And therefore you see either no effect or increase in the risk of, like we saw in the heavy smoker. So it was a fallacy that it was not scientifically correct to start the experiment with a single antioxidant because of these reasons. As you know, the cell has an environment, lipid environment, has a aqueous environment, and if you just use vitamin E, it will protect only lipid environment. But 80% of the cell is water. And there are many vital molecules are floating around, and they won't be protected by vitamin E. So, there are a whole bunch of other reasons. And so it was not a good idea scientifically to start a trial. And so now, doing that, what we have proposed, that if you have the question is, how can you reduce oxidative stress and inflammation at the same time? We have proposed the idea, and we have published this work. We have proposed the idea that in order to accomplish this, to decrease both oxidative stress and inflammation at the same time, you have to have a micronutrient preparation, a mixture of micronutrient preparation, which can reduce these two at the same time. Like, for example, we not only increase the level of antioxidant that we take from the diet or our body makes it, but also we have to increase the antioxidant enzymes like glutathione peroxidase, catalase, superoxide dismutase. We have to increase those antioxidant enzymes and antioxidant compounds, both at the same time. So how we do that? Well, to increase the antioxidant compound like vitamin E, vitamin C, it is easy to supplement them and then increase it. So that's easy, multiple antioxidant. But then how do you increase the antioxidant enzyme? In order to do that, you have to activate a NRF2, and NRF2 is a nuclear transcription factor. This is absolutely essential. Activation of this one is absolutely essential if you want to increase the level of antioxidant enzyme, which is necessary for reducing oxidative stress and inflammation. But what happens that normally NRF2 activation requires free radicals, a small amount of free radicals. But when you have a chronic stress, chronic inflammation, chronic oxidative stress, they don't respond anymore to free radicals. And therefore, the antioxidant enzymes remains down. And if they are down, they increase the oxidative stress. So the question is, how you do it? So somebody has demonstrated that some antioxidant like vitamin E, the glutathione, alpha-lipoic acid, certain vitamin can activate NRF2, which has become resistant to free radicals. Now they can activate it. And when they get activated, they migrate from the cytoplasm to the nucleus, where they bind with another protein called antioxidant response element. And this binding is absolutely essential to transcribe more gene expression for antioxidant enzyme, and then antioxidant enzyme level increases. So, so we have prepared a mixture of micronutrient which can not only elevate the level of antioxidant compound, that some of which we take from the diet, some of which our body makes it, so they will be elevated, but some of these micronutrients that we have in our formulation can also activate NRF2, which has become resistant to free radicals. And therefore now you have also not only increasing the level of antioxidant compound, but you also increase antioxidant enzyme level. So now it is perfect combination to decrease the oxidative stress and inflammation at the same time. So we have proposed this could be very interesting for for prevention. That's one thing. Now the question is, that if you start earlier, and also probably you all know it, that brain uses a lot of oxygen. Brain takes about 25% of respired oxygen used by mitochondria. And mitochondria cannot handle that much oxygen that it takes. And 2% of that oxygen leaks out and generates billions of free radicals in the brain. Not only that, but mitochondria, during producing energy, as you all know, they also produce free radicals as a byproduct. So then you would have thought that brain should have a higher level of antioxidant. No, brain has the lowest level of antioxidant to protect it against massive insult of free radicals. Not only that, but membrane are more sensitive to oxidative stress or free radicals than any other place in the cell. So brain gets exposed to highest level of oxidative environment, and gradually neuron, after the age of 25, they gradually you start losing the neuron. And when you become old, there's sufficient amount of neurons are lost, then you develop all the symptoms of the disease, Alzheimer's disease. So the question is that how we can reduce that? Well, as the guideline suggested, federal guideline, in addition to modifying your diet and avoid any risking agents of environment, and you can't avoid certain things, but you try to adopt as much as possible to improve your lifestyle and diet and so on, but also takes a micronutrient mixture that can do the job that I mentioned to you. And this will be very important from the prevention point of view, because you will take care of both oxidative stress and inflammation at the same time. And this is not only Alzheimer's disease. As you know, that these two factors, cellular damage, are involved in many other diseases, Parkinson's disease, and arthritis, and you name it, every place they are involved. So you will have a healthy lifestyle and also prevent the risk of dementia. Now, the last part I will take a few minutes is how you treat once you have a dementia. Well, current treatment is, because as you know, it is the loss of cholinergic neuron, which makes acetylcholine, and acetylcholine is the compound which restores your memory, inability to learn, and all this kind of related to memory. And so what the drug is right now, that they use what is called cholinesterase inhibitor. In other words, the enzyme which degrades acetylcholine are used to treat Alzheimer's patient. And one of the most recent one was Aricept. And they improve your memory functions, but they don't last for a long time. They last average 3 months, occasionally last for 1 year. The question is why? Why such a good drug can't be effective for a long time? Because these drugs do not address the increased oxidative stress and increased inflammation. These are happening in the brain, and these drugs do not address that. And these two, increased oxidation and inflammation, are killing your cholinergic neuron. And if your neurons are not alive, your drug cannot be effective, because these drugs' effectiveness depend upon that cholinergic neuron remain alive. Once they are dead, there's no place to increase the acetylcholine level. And therefore, we feel that if we combine with the cholinesterase inhibitor or any kind of drug we are using it, then you will be able to improve, because by using a micronutrient mixture, you are preventing the death of cholinergic neuron, and therefore effectiveness of drug, any drug that you are using it, will last longer. Another very important point is that, for example, even the person who has already a lot of beta amyloid, and there any kind of drug can't help because this is already formed there, and they are going to kill neuron. But the last steps, damaging effect of amyloid protein is generation of free radicals. In other words, even amyloid, why it kills neuron for cholinergic neuron? Because they generate also a lot of free radicals. So by using micronutrient, not only you are increasing the effectiveness of cholinesterase inhibitors, but also if there are some already formed amyloid protein, you are preventing that damaging effect, and therefore you will save the neuron so that these drugs can last for a longer time. This is very important. And but there is no strategy right now. This is such a common sense phenomenon. It is that you just look at literature and they will tell you that increased oxidative stress and inflammation are the central to the initiation and progression of dementia. Not only that, even in the cases of family history, for example, who has a family history of mutation of APP or Preselin-1 or Preselin-2, and then right now there is no strategy to delay the onset of the disease. You wait for the symptom to appear, and then you start treating the symptoms. But people have published, not me, but other people have published literature showing that those people who are carrying a family genes of Alzheimer's disease, before the symptom appears, long before the symptom appears, the level of oxidative stress and inflammation is very high. So the question would be whether, if by using a micronutrient mixture, whether we can reduce the oxidative stress and inflammation, which initiates Alzheimer's disease, and therefore delayed the onset of Alzheimer's disease. Instead of at 35 to 45 years of age, you can develop 95 years of age, who knows? But it is possible. Nobody has done the experiment. It is based on scientific knowledge that we have. We are proposing these kind of ideas. And I will be glad to answer, some questions that you may have from the audience. But we feel that the appropriate micronutrient mixture that we have. And also one more thing that you may not know by this time, that recently FDA has approved a monoclonal antibody against the beta amyloid protein. So if beta amyloid protein is already formed, this medication removes the beta amyloid. It doesn't do anything to prevent the formation of beta amyloid, but if it's beta already, because this is antibody, this binds it and makes them inactive. But here is the literature. There is no human data to support that. But the collagen, as you know, collagen is 25 different types of collagen, but collagen 5 is present in nerve cell. And what people have found in experimental system, that if you treat the cell with the nerve cell, with the beta amyloid will kill the nerve cell. But if you add the collagen peptides there, they prevent the death completely. And so, and in animal model, by giving this the collagen peptides, the animal which has already formed a plaque, they remove the plaque, because this collagen also binds with the amyloid, just like antibody. It also binds with the beta amyloid and make them inactive, so it can't cause any toxicity. And the monoclonal antibody, as you know, their cost is $28,000 per year. And there was some opposition in the FDA that this is not a good medication, but nevertheless, FDA approved it. And so, because it is not very effective, really. And so And so, but collagen peptide, we don't know because this is only an experimental system we have. But it is a potential anyway, it is non-toxic. And so if you combine all these that we discussed, micronutrient, that we mixture of micronutrient plus collagen peptides, that could be very useful, not only in preventing, but also in combination with a standard therapy, whatever therapy your doctor has recommended, it can improve the effectiveness of the therapy that we are currently using it. This is all I have to say about this. I'm sure I have missed many points. Next time I present, I will have a slide and I can do a better job. But anyway, I will be glad to answer any question that you might have.
Dr. Prasad, this is Dr. Patel.
Yes.
Can you hear me?
Yes,
Okay.
Dr. Patel.
So in micronutrient, it's a mixture of the antioxidants as well as the nerve to activation nutrients.
What agent you said?
In micronutrients,
Uh-huh.
you have like a 2 or 3 different kind of agents, like one which are antioxidants.
Yeah, I
Second
think,
one-
micronutrient that you are talking about, that do we have different kind? Yeah, we have all vitamin, not all, but most of them that we take from the diet, and also endogenous like coenzyme Q10, alpha lipoic acid, and of course vitamin A, C, E, D. We also have all B vitamins because they play a very central role in brain function. And so it is a comprehensive mixture of antioxidant. We also have a resveratrol, curcumin, because as you know, resveratrol has unique function, not only as a antioxidant or anti-inflammation, but it also stimulates the mitochondrial function by protecting the protein called SIRT1. So we have very extensive approach and of this micronutrient, and again, we have tested, as you know, that we work with the Department of Defense Laboratory for our initial formulation, and we tested them with the Marine Corps in training. We tested on a veterans who has a traumatic brain injury, and we got an extremely positive response.
That's wonderful. So collagen peptide, which collagen peptides did they try? I know it is in a research, but.
Yeah, I think collagen peptide has done it, but some of the people who have done in collagen peptide research for a long time, and again, effectiveness doesn't last very long because the enzymes, again, they're also increased oxidative stress will increase the activities of collagenase, elastase, and another one is MMPS, matrix metallopeptidase. And these enzymes degrade collagen. And collagen is degraded also directly by if your body is producing a lot of free radicals. And when the collagen gets damaged, then of course proteasome can remove it. So what we have done in our approach, that we have used the collagen, the enzyme inhibitors of the collagenase and elastase, and the 2 sources we have used it. One is the amla extract, as you probably know, Dr. Patel, that India, this is Ayurvedic medicine is routinely recommended for varieties of illness. But our interest was collagenase inhibitor, and is very rich. And we also use a white tea extract. And the combination is more effective in reducing the degrading enzyme collagenase and elastase and MMPS. And so we feel that if you do this in vivo, the effect will be much more lasting, and because the enzyme will not be degraded. Plus, we are always using a micronutrient that we have, and so they will also protect the collagen already formed from free radical damage. So you have approach in 2 different directions. You are protecting the already formed collagen from free radical by micronutrient. You are also inhibiting the enzymes. So I think We have not done any human study as yet with the enzyme inhibitors, but this is what we are proposing it.
Thank you. So the white tea extract you are talking about, is that from the oolong tree?
Yeah, it is an extract. I think it is, David can probably address more. It is a caffeine-free extract from the tea, green tea. And it is water. I mean, it is water extract.
Okay. Thank you.
Mhm. So in that way, our formulation is kind of unique. So it is a combination that will do the job. If you just use the collagen, it will have some valuable effect because we have enzyme inhibitor. But if you use the micronutrient, you are taking care of many other health issues that you may be confronted as you grow older.
You're talking about collagen peptide, not collagen itself, correct?
No, because collagen, that will be very problematic because you might have induced allergic reactions and all these kind of things. But collagen peptide, because they get converted to amino acid very easily and they get absorbed amino acid. And as you know, they have 20 different varieties of collagens and each has its own genetic genes. But cell decides once you provide the amino acid, then some cells need type 1, type 3, then they make their own because we have provided all the amino acid they need, and therefore they can decide depending upon what their needs are. They have been doing all these years. They will make their own different type. For example, collagen only 5. Only in skin they have collagen 1, collagen 3, major 1, but in brain you have collagen 5, only a small amount of collagen 5. And it's interesting to know that collagen protein represents 30% of your total body protein, 30%.
So that means that there are people, those who are taking collagen drinks, they think they will increase their muscle endurance and skin and etc. So do they put themselves at a risk for developing some neurodegenerative diseases?
No, because if you are taking it, first if you are taking without, no, because the collagen declines it. Therefore, replacement of collagen is very important to at least reduce the rate of aging of your. Eventually, everything will age, but at least it will reduce the rate of aging and age-related any kind of disease that we have. And you cannot produce because the cell makes it according to their needs. Until you have a genetic problem, then this is a different issue. But there are very rare genetic problems where excessive accumulation of collagen can create a health issue. But in a 99.9% of the cases, each organ makes their own an amount they need to function properly.
Thank you.
So there is no excessive deposit. First, if you're just taking a collagen, it won't be very long in your systems anyway, because you have not taken care of free radicals, you have not taken care of this thing. But even if you've taken care of, like we are suggesting it, then the cell or the organ makes only that much that they need.
So then why does the brain makes more, or what happens during the Alzheimer's then? If that is true, the organ makes what they need, and you said there is a problem in the brain, the collagen in the brain. So do they make it more, or just the?
No, I think, for example, collagen 5 in the brain, they will make collagen 5 in the brain and it will be very protective, and the rest of them are eliminated. You might go to, amino acid might go to excessive amount in the brain, say, for example. Many nutrients can go, but all the nutrients that we provide Cell takes only what it needs. I mean, this is homeostasis, and excessive amount gets eliminated from your system.
So have you found that a certain medication, it works better than the other in cases of dementia?
Dementia, well, when you medication that right now is the best medication is the cholinesterase inhibitor. And some other is they use also the agonist of muscarinic receptor, which also increases acetylcholine level. But currently, most of the time they are using right now is the cholinesterase inhibitor. And all are based on the principle that neuron has to be alive, except the monoclonal antibody. But most of the drug approach they presume their effectiveness can work only as long as neurons are alive. But once the neurons are dead, they become ineffective. And that's the reason micronutrients come into picture, because these drugs, none of them decreases either oxidative stress or chronic inflammation or neuroinflammation.
So at what age would you think that one should start taking it as a more prevention agent? Because 30 and 40 years are very hard to say, but what about 50, 60? What
I think, for example, you started losing neuron, I think it's a 1%, I forgot exactly number, 1% every year. And that's a lot of neuron leaving it. So because brain is exposed to high levels. So I would say that these kind of approaches should be started anywhere from between 40 to 50. Because by the age 65, your risk becomes too long. So I would say that we will start around 40. That will be the ideal. And for me, it is too late because I'm 87. But still I'm functional mentally, physically. But in any case, for prevention point of view, I would say, and another example I will give you why it is so important, this thing for prevention point of view, as well as prevention point of view, especially in case of genetic. We did some study on fruit fly in collaboration with NASA at the Moffett Field, California. And my colleague was Bhattacharya. She was a very expert in a fruit fly genetics. And so I collaborated with her. And what she did, she inserted the genes, human genes, which causes leukemia in fruit fly. And so fruit fly now generally don't develop tumor. But once you inserted the cancer-causing genes, then they started risk of developing cancer increased. And she was interested in proton radiation, and proton radiation is 10 times more effective or more damaging than X-ray or gamma ray. And the reason she was interested in proton, because our astronaut on lunar surface, when there is a solar flare-up, they get exposed to proton radiation. And that's the reason she exposed. So when she exposed fruit fly, who has injected the cancer-causing gene, now over 90% of the fruit fly develop cancer. So I told her that maybe we should try micronutrient. So I gave them a formulation of antioxidant that we have in our formulation. And because I thought that they don't need B vitamin. So I just gave the multiple antioxidant preparation, and she fed the fruit fly through the diet 7 days before proton radiation, and continue to give 7 days after radiation, and none of them developed tumor. So this is a demonstration that even the genetic basis of the disease can be prevented or delayed, at least at least in a fruit fly. We cannot extrapolate to human from fruit fly, but at least raises the possibility that even the genetic basis of disease can be delayed by micronutrient mixture.
So can that be also used in people, those who have a cancer, those who are getting radiation, and then after a while they have a radiation injury, but then they are not getting radiation, like post radiation.
Yeah, we always recommend, because you know that the late effect of radiation or chemotherapy, both, is it could have a new cancer in some 10% of the cases, or it can have a reoccurrence of the primary tumor, or you could have a delayed non-cancerous diseases. Like a most classical one is the wound healing is difficult to heal if you have a radiation-induced wound. And so there, yes, because again, same principle is involved: increase oxidative damage or stress and inflammation. And if you can reduce it, then late effect of radiation can be delayed, can be reduced markedly. And you know, I have done a lot of work on radiation protection study, but again, nobody had looked into human, but in an animal model, this makes sense. There are a lot of studies that have been done, and so I think we feel that you know, either before that you have prevention issue, or after completion of radiation therapy or chemotherapy, then you use the micronutrient mixture. Not one micronutrient, because that will create a lot of problems.
Right.
But
so in amla, did you use the amla extract or amla powder?
No, I think we use the amla. I think they must use it when you make a capsule. I think they powder. They must have used powder, because collagen peptides is in a powder form, and so amla fruit extract it is, and so they must have in a powder form. Yeah.
So there were some fruits with the red pigment in it too. So you don't think the red pigment fruits and berries would be very helpful?
Yeah, I mean, anytime you in a diet, for example, amla extract, this has also a lot of antioxidant activities, and so if you take it in a diet, lot of fruits, but see the fruit, few people can follow the principle that dietary intake that you take is not sufficient to increase the level that you want to have it in your body to prevent the risk of a poor health, increase oxidative stress and prevention. So that's why it is very important to have, in addition to taking the best diet you can, then you take this micronutrient mixture. This is what we feel it, and what my recommendations are. And so, because this will give you optimize not only the risk, but also immune function is extremely important. And to fight any kind of infectious diseases. And by giving a micronutrient, because we don't know, not many people have a good diet. As you know, in the United States, most of the people suffer micronutrient deficiency. And even micro deficiency of one can impair your immune system. And so RDA value is, for example, is okay to make sure that you develop regularly, you develop disease and you die. I mean, RDA is not sufficient to prevent any kind of a age-related poor health that you often do it. Because most of the people take RDA amount, but still they develop all these kind of...
Have you used the pomegranate in your preparation? Pomegranate, dadam. Pomegranate with the red berries inside.
Oh, pomegranate, yeah, no. Well, I think, once you optimize your situations, there are many things that can be very good. Pomegranate is one of them, is very important. If you can keep, I eat myself. Whenever there is a season for that. And so, yeah, that is a good one. But again, you can have it, that will help you, but that's not sufficient that you say, I can't have any additional micronutrient. Because some of these things have a certain micronutrient, but the way we prepare our micronutrient mixture, it has everything your body needs, all at the same time. See, sometimes you can have one, but not the other. That's the problem with the diet. Sometimes you have certain things, but not the other. But what we provide is all at the same time. Because this is very important, to reduce oxidative stress and chronic inflammation at the same time.
So you have glutathione in it?
Beg your pardon?
Glutathione.
A glutathione. No, glutathione, we have a glutathione elevating agent. This is very important. If you take an oral glutathione, it gets hydrolyzed in your gut and your body never sees it. And therefore, we have done it alpha lipoic acid, which is there. This increases glutathione peroxidase and increases the level of glutathione. But we also gave it a synthetic one called, N-acetylcysteine. But the reason we gave N-acetylcysteine, because as you know, glutathione is the most important antioxidant in your body. It is present in a millimolar level. And so how do you do optimally increase we have a alpha lipoic acid, but you also give N-acetylcysteine because this will get absorbed better when it goes to your bloodstream. N-acetylcysteine is chopped off and cysteine is used as a substrate to make additional new glutathione. So an enzyme can have plenty of substrate to make a new glutathione. So the combination of both alpha lipoic acid and N-acetylcysteine can increase the glutathione level optimally in your body.
Okay. So Dr. Patel, I got a few questions in here. Can we use dementia medications with the antioxidants, or do they negate each other?
Yes, that will be very important. If you are taking dementia medication and if you take a micronutrient mixture that we have, it will be complement. It will improve the effectiveness for a longer period of time. It won't be a counterproductive at all because both work in different ways.
Did I miss how we did? Do you do any testing for micronutrients to make a customized formula, or do you?
No, we have a formula that is a kind of a level that is sufficient for average man or woman from 20 age to, from 18 to forever. I mean, 18 plus, because we have given a dose enough that some of these either weight differences or age differences doesn't make any difference.
What is better? There's a question. What is better, plant-based or keto diet for dementia? What is better, plant-based or a keto diet for dementia?
Oh, I think plant-based diet is always good. I would say, but keto diet has some advantage, some disadvantage. But keto diet, if you take a micronutrient mixture, some of the problems that could be associated with keto diet could be prevented. But plant-based diet is always very good. And if you are a non-vegetarian, you can eat fish more often or white meat. Reduce the intake of red meat. That's what one of the recommendations of the Alzheimer's Association in terms of diet, that you use a plant-based diet, and if you want to have meat, then take a fish or white meat like chicken, but not red meat like beef. Or if you do, people who like beef, maybe reduce the consumptions. See, that's the problem with the diet, is not many people follow it. Like to, and that's why, I always say that try to follow the guideline as closely as you can, and then take a micronutrient supplement.
How is your program different from Dr. Terry Wall's?
Dr. whom?
Dr. Wall's, I think that's from the multiple sclerosis.
I don't know, but I have looked at many one, but I have not looked it. I will be glad to look it if you send me their formula. But what we have done is
scenario.
Yeah, our formula is the only one which has been tested clinically. In a human, in a variety of health conditions, even in like tinnitus, for example. Tinnitus, there are 40 million Americans which has a tinnitus or ringing of the ear. And we have performed a human study by audiologists in Nashville, and for a 12-week period. And within and 70 patients was involved when this was published work. And they found that within 12 weeks, the symptoms of ringing of the ear or tinnitus was markedly reduced. And so it is also hearing loss is a major problem as you grow older. And they're also in hearing loss, and I have published a paper on these issues. There is increased oxidative stress and chronic inflammation are involved. So if you start earlier, then hearing is not a hearing risk of getting hearing disorders will be markedly reduced.
Mm-hmm.
Because we have tested it. For example, we tested, so other people may have a formula, but we have tested clinically. We have tested in animal model, for example, radiation protection. We collaborated with the Radiobiology Research Institute of the Department of Defense and found that at the dose of radiation where all mice are killed, and if we give them micronutrient mixture, they 40% will live. And so, even for example, I gave an example of veterans coming from war in Afghanistan and Iraq. They go to Naval Medical Center in San Diego, and they were having they were exposed to a traumatic brain injury. And Dr. Captain Hoffer, who was the captain at the time, and again, as you know very well, that these all protocol has to be approved by the Navy Institutional Review Board, called IRB. Without that, we cannot do any experiment on anybody there. And so we found that these veterans who were exposed to traumatic brain injury, showing these symptoms of balancing problem, dizziness, and very poor quality of life. And so the Captain Hoffer divided two groups. One group got the standard therapy that they have been getting all these years. Another group got a standard therapy plus our micronutrient mixture that we developed. And we found that 12-week study, and he has quantified by measuring each criteria and found that within 12 weeks, the combination group did much, much better on all criteria than the standard therapy group alone. So, we have done a lot of human studies, and another study we did from University of Montevideo in Uruguay, where the volunteers was a normal volunteer anywhere between 25 to 35 years of age. And as you know, in South America, they are chain smoker. And so we gave them this micronutrient formulation, and it was a 1-year study. And the measurement was the immune function measurement, oxidative stress. So oxidative stress was gradually decreasing, and immune function was gradually improving. So we have tested, and it was totally safe. And so we have tested a lot of it. So many people could have a formulation, but we have tested it, and it has shown the result that many times we didn't expect it, but like traumatic brain injury, but it was there. So if you give me the formula of anybody, then I can compare with mine and see how it differs. Right now, since I don't know, I won't be able to make a comment, except that ours is the most clinically and experimentally tested product in the market.
Okay, I'm just asking, relaying the question. So
Sure.
okay. Well, here's another question. So I'm the hormone guy in the group, and I have protocols for traumatic brain injuries for hormones and hormone balancing, especially for traumatic brain injuries. Have you looked at combining different modalities?
Yeah, I mean, for example, hormone. I'm glad you mentioned that. The hormone, again, the first, as far as the oxidative stress is concerned, when you are younger, men has a higher level of oxidative stress than female. But after menopause, female has become as high in oxidative stress and chronic inflammation as men. So there's a sex difference in terms of how you do it. Now, as far as the hormone supplementation is concerned, there are some questions raised. It's controversial because some people say, for example, that's what your question, I guess, hormone replacement therapy, whether it's estrogen supplement, take for estrogen replacement therapy. If you supply, you do it, you reduce oxidative stress. And as you know, because the one reason why woman has a higher level of Alzheimer's disease is because of loss of estrogen. Estrogen is protective agents against oxidative stress also. But the question has been raised that the one experiment, at least in one experiment, clinical study, that replacement therapy cause a lot of side effects if woman has it, the hormone like estradiol replacement, and increases the risk of cancer. But here's my point on that issue, and because it is a controversial, there has been experimental data available that estrogen is not a carcinogen. It is a tumor promoter. In other words, if somebody is already, some chemically have already initiated, say, breast cancer or ovarian cancer, then estrogen can help to make it a cancerous. But what experimental data suggests that if you take vitamin E, they block the tumor promoting effect of estrogen. So if you are taking a hormone supplement, in my opinion, with estrogen, with micronutrient, probably you don't have to worry about, but there is no experimental data to suggest that. Same thing is testosterone. And so replacement therapy, because of the controversy, we have avoided that.
Well, I'll debate with a lot of those things with you. We have ways around all of those things. So, for instance, first of all, a lot of the tumor issues, especially with estrogen, had to dealt with using synthetic estrogens, which we never use anymore.
Sure.
Secondly, we never treat any patients with any types of estrogens without balancing them with progesterone.
Yeah,
and that seems to be the key to making to keeping the tumors under control. As far as testosterone is concerned, again, it's the type of testosterone that's being used as a replacement. If you're using the synthetic ones, the pharmaceutical company ones are all synthetic, and that's where we run into issues. So, so another question. So that's kind of my short answer to that. So
yeah.
Can brain function be worsened if estrogen is given 10 years away from menopause?
Brain function?
Yeah, is it worsened if estrogen is given 10 years away from menopause?
No, I think, that study had one that if you give earlier, say, for example, 10 years before onset, then that side effect is reduced. Any potential side effect, chances. So it is very productive. It is very good.
Right, if it's given, within the first 10 years. But the question is, So what happens if a woman shows up and she's 72 years old and she's showing some small signs of dementia, and obviously they're going to have some hormonal deficiencies? Then what?
Yeah, then as a physician, you can make a decision. But I would suggest that for micronutrient point of view, I would say take micronutrient, and also in that case we have a brain boost, which has specifically to improve brain function, and I will say take collagen, and then hormones replacement therapy. You are a doctor, so you can do. I cannot do it.
Mm-hmm. Right. Okay. I'll answer that, Dr. Nario. The answer is estrogen drives blood flow to the brain, and adequate estradiol levels will increase blood flow by 224% and decrease luminal thickness, or improve luminal opening by up to 224% within 6 months.
Sure.
So the answer is So one of the guidelines is don't use hormones 10 years post menopause. And I don't know where anybody got that. They made it up. It's really made up. It's another, it was another one of those knee-jerk reactions after the WHI study in 2002. Remember, hormones were bad. We couldn't use them at all. So, And it didn't matter what type of hormones there were, which, was
Well,
again,
I can add to it that those ladies, those who have a TIA kind of symptoms,
mhm,
postmenopausal, if you give them the estradiol, then it helps because it does the endothelial, improves the endothelial dysfunction.
right,
Besides increasing the blood flow, it's very important
Right.
that endothelial dysfunction improves and it remains open.
Yeah, I mean, you're correct. I mean, estrogen is so important. And once you lose estrogen or decrease the level, you have a lot of issues, especially menopausal women. And the question is, the doctor has to decide what to do, how to do the replacement therapy. I mean, that makes sense,
mhm,
but when the FDA and other people have raised question, for us, it is difficult to make especially for me, because I have a PhD, you can make a suggestion for sure. But I can say that, that micronutrient can be very helpful no matter what you do and how you recommend it. It will be very useful for your brain function, for your overall health, for your immune function.
mhm. And I'll just give my little, my own little mini advertisement. There's my email address. Remember, we have it's actually it's an 8 lecture now. One of them is not CME approved yet. 10-hour CME course on introduction to bioidentical hormones, 10 CME credits for AMA and AOA. So
Good.
there's my commercial on that.
That's good. That's all right.
Send it to everyone. You send it to participants.
Oh, send it to waiting room. Sorry, send it to waiting room people.
There you go.
I'll do it again. Okay, hang on. Keep talking, Dr. Prasad.
I think it's time to find out how to get the product and what is the price of the product.
Well, David is here. I think David can
Yeah.
talk about business aspects.
Thank you, Dr. Prasad. Wow, what an amazing discussion. It's really inspiring to me to hear people of excellence and the knowledge that you have asked these questions. And Dr. Prasad, thank you again for the lifetime you've invested so you can have answers as it relates to micronutrients. On the business side, we have a really simple professional program. Depending on the product, like our Micro Daily, which is the military version of the product, that's approximately $53 a month to a consumer, but we have a professional program where you can, as a professional, have access to that product. It's just a little bit over $30, and then you can bring your clients and patients in as customers. We also have a financial model around that. I know that you're more focused on the health and wellness of the patient, but I think, Nancy, you're on the call. I think, would you be the one that would want to talk to any doctors interested, and you could help work with Taya, who's in our company, specifically in the professional program, work with Taya and help people get set up?
Yes, that would be perfect. So we can give her Taya's number, and I can connect you and get you all your information on how to become with our professional program and get you set up.
Yeah, so as professionals, we have a 50% discount from retail, 33% discount from our wholesale price. So you get it at the absolutely best price. And then there's a very simple program for how we can get your customers signed up on a subscription and be taking the product hopefully every day for the rest of their life. That's what our objective is, because we know it will enhance their health. But Nancy is here to help you. And then we have Taya, who runs our professional program here at the company, and they can help you with anything you need, materials, getting set up in the system so that you can order product and sign people up who want to sign up. So that would be the way that I would recommend it, would be to connect with Nancy. Is that okay, Dr. Patel?
Yeah.
Yes, that would be great. But what about giving her phone number or email address?
Well, I was going to say, Nancy, could you put your contact in the chat there so everyone can see it?
So Nancy will type her email and phone number, and then you can reach out to her directly. Any of you who are interested. I think, the information Dr. Prasad provided hopefully is giving you a lot of insights into micronutrition. You can choose to dig deeper with any of his books or knowledge. Also, if you'd like, we can make Dr. Prasad available for individual discussions.
Yeah.
And that would be through Taya, also who runs our professional program. And then Dr. Prasad really made it easy. He's got the formulation. You don't have to be the expert on the micronutrient piece. He is. That's what he's dedicated his life to. And we've got a really simple way to get the product to people's hands, shipping it directly to their house if they would like. So
What
we've
about
got
Brain Boost?
what about
What's
what?
the price for the Brain Boost?
The Brain Boost is $29 a month. And then if people buy it in with the Micro Daily, right now we discount at $10. So it'd be $20 a month if they buy it as a bundle with the Micro Daily.
Sounds like we all need it here, right?
Yeah.
It's helpful to everybody.
I'm taking every day.
We've really tried to make our products affordable to the masses, but I can tell you they are not cheap products. Every manufacturing run we do is tested by third parties to validate and verify quality, safety,
Yes.
and purity. And so the products are of the highest quality, and your patients will love them. Here's I think the best, I guess you could say, validation of how effective they are. At 12 months, we have pretty much a 70% retention rates on our products. And for the supplement industry, for 7 out of 10 people to stick with a product for over a year is really unheard of. I give Dr. Prasad credit for making products that work. And I give you and our other health advocates or affiliates credit for educating and informing people on why these products will help them, so that they give them the chance they need, and Dr. Prasad recommends that people try it for 3 months. Take it every day for 3 months. And if you're not seeing results, then you can judge it, but give it at least 3 months to help it impact your health. We see impact much more quickly than that. Some people are impacted within days or a week. Most people see significant positive results within a month or two, but at least 3 months is what Dr. Prasad recommends. Correct, Dr. Prasad?
Yes, yes.
What about collagen? Or you were talking about collagen product, something?
Yeah, the collagen is $59 for a month. So as a professional, you'd be buying it at a 33% discount from that. And you could sell it at $59, or, you can have people come directly to our website and buy it as a referral from you, and anyone that you refer, you get a credit for. And we have a pretty compelling commission program. We have a lot of doctors making significant benefits from that. But once again, that depends on what your mindset is and how you want to approach the product.
Do you have any patient literature?
We do have, we have literature that you can share with them. We have one-page pieces on every product. We have videos on every product. We have handout cards that you can use in the office. And Nancy and Taya can help you get set up with everything you need to share this as simply and integratively in your practice as you want.
Okay, terrific. If you didn't hear me at the beginning, though, please, everybody, stick around for a few minutes when we're finished. I have something that I need to bring up that's quite daunting for all of us. So please stick around. So Dr. Prasad, we can't thank you enough, and your team, David and Nancy. I know they've been in contact with me ever since we came. We first contacted you. You guys are, top notch and terrific, and please thank you all for being with us. I know everybody here is always most interested in what you're doing, and hopefully, down the road you can come back and give us an update.
Sure.
And if there's anything that we can do for you, let us know. This video will be on our website, usually within 48 hours or even less. It's free. It's at aosrd.org. Let me put it in here, /webinars, where all of our aosrd.org/webinars, where all of our Tuesday night lectures are. We've been here for almost 2 years. We have quite a library of lectures now, that we've accumulated. Also, anybody that was at the conference, the videos are up finally. They're in a raw form, however, they're by days. So we're still trying to get them separated. They are password protected, for those that paid, to get in. So if need be, let me know and we'll get you the password. So now, Dr. Prasad, any conclusions, any final thoughts?
No, I think, in my opinion, that's what I do.
Okay.
If you take a micronutrient, brain boost, and collagen,
Mhm.
and sometimes eye boost also. I forgot to mention eye boost. As
Mhm.
you grow older, there is a lot of eye-related issues. Some of them are genetics. And under those kind of conditions, depending upon your health conditions, but at least the brain boost and micro daily and collagen, I would say, and if you are older like me, eye boost, these are the 4 main products that, that I say people to take it depending upon
So-
health condition, age,
so-
and so on.
Can we put you on the spot and ask you if you take your own products?
Yes,
It's like somebody who, owns a restaurant. Would you eat in your own restaurant? Right?
yeah, right. I mean, I have been doing this for a long time, and I really do credit for these kind of issues. I also take good diet. I do exercise and so on. But I was a very good tennis player in the past, and so I have been. That's why I'm functional at the age of 87.
Yeah, you're really 94, right? You matured well. So,
Yeah.
all right. Well, we can't thank you enough.
Thank you,
Thank you so
Dr.
much. We're
for
getting
inviting
thank yous in the chat from all our, all our participants either. So next week, just as an aside, is Dr. Harding still on? He was on. So Dr. Dennis Harding is going to be on. He's a chiropractor. He specializes in C1, I believe. Now, Dennis, you're on. So Dennis, you want to just real quick what your topic is?
I'm one of about 400 people in the world that is an expert on C1, restoring blood flow to the brain for brain function. So there was a lot of talk about that tonight. So we were able to help that vascularly there. But that's what I'll be talking about is what we do, how we do it, and who does it around the nation.
So notice the theme.
The brain.
Okay. Yeah.
Yeah.
All right. So unfortunately, next week is the American Osteopathic Association's House of Delegates. It was brought to my attention last week that there is a proposal in the House of Delegates, a resolution to decertify us as the American Osteopathic Society of Rheumatic Diseases. The alleged reason that it was brought was because we have strayed from our mission from rheumatology and autoimmunity. We no longer hold that mission. The real reason is that apparently there's been a lot of animosity between my predecessors and some people on the board. And apparently that they've been trying to decertify us for many years, well before I showed up on the scene. Dr. Burgess knows a lot more about it than the history than I do. Anyway, I wasn't going to go. There's 245 pages of resolutions. This was buried on page 178, and we wouldn't have even known about it except Dr. Clower, who's the assistant vice to the president or something of the AOA, called me last week and told me about it. So we are going. I wasn't going to go, but we're going to mount our vigorous defense because like I said, the main complaint is that we're no longer focusing on rheumatology. The second complaint is that we are overlapping other subspecialties, which I don't know what subspecialty doesn't overlap another subspecialty. And just as a jab, the third is that we only generate $19,000 a year for the AOA, which is nothing to them. So we've been generating our response. And they told me they'd give me, usually you get 2 minutes to, as an addendum. I don't know how long I'm going to have to speak. But what I would like from you all is a short testimonial into the quality and, and if it's in your heart to talk about this program that we've been running for 2 years, our fall OMED programs, our spring conferences. Those of you that been to it either live or online, can attest to, how, to the quality of our programs and to the fact that no matter what our topics are, like tonight with Dr. Prasad, we always have as our core of autoimmunity and rheumatology, every one of our programs. And I'm not sure where this came from. And quite frankly, if I hadn't been told about it, we wouldn't have even known about it, and it would have passed through without our even knowing anything about it. No one talked to us. No one said a word to us. It's in a resolution. It's on page 178. If you go to the AOA's business meeting House of Delegates, if you do open Apple F or Control F and go put on AOSRD, it'll show up. The main offense was an ad that I wrote 4 years ago. My first year running the conference, we had advertised with a medical conference database called emedevents.com, and we had spent $1,000 on this ad. Those of you who have been around for a long while know I started out in 2018 with $822 in our treasury. So that was a lot of money for us to spend on this. And we got the American Osteopathic Society of Rheumatic Diseases is not exactly a thriller, especially for mostly general medical folks. So, the comment I heard was that, well, you're a rheumatologist, you have nothing to do with me. So I wrote an ad, and in it I wrote that we were the integrative medical subspecialty within the AOA, and that they picked that out. It's an ad that was 4 years old, and that they picked out, and that's what they're trying to use to hang us. So we've been working for. I've only known about it for a week. John and I have been working on it, and I have a couple of other colleagues on our response. If anybody has any thoughts to what as to as talking points, please let me know. What we really need are short. It doesn't have to be long, 3 or 4 or 5 lines, testimonials to the quality of our programs, and that. One of my questions in there is that what does decertifying, how does decertifying us aid advance the function of the AOA? And the answer is that it doesn't. So if I could
say one thing, just to make it clear to everybody, the proposal, as I believe that I read it, focused on one statement that just shows it was a setup and there's no logic, reason, or anything proper about this. It said that our organization, after 50 years, has not been advancing osteopathic rheumatology. This is what they're saying our crime is. We are not advancing osteopathic rheumatology and rheumatologic diseases, which includes the autoimmune diseases. And I think we have advanced it more than almost anybody in our profession. And to deny that micronutrients play a factor in rheumatology, electromagnetic fields, acupuncture, herbal, lifestyle, hormones, if they say that is not involved with autoimmune disease and rheumatology, this whole thing is a setup. So it's not about being reasonable, kind, polite. It's a matter of a few people behind the scene trying to take out integrative medicine and things we've been working for about 50 years.
Right. So,
And the
Um,
word the president said, he wants compelling testimony. If we could get compelling testimony, that would help us.
so we see a couple of new folks on here. Dr. Johnson, we've not heard from you before, but thank you for coming. Kylie, I know you've been with us for a couple of months. Dr. Gerber, you're an old timer at this. So anybody, those of us that've been around, Dr. Richwine, I know you've been around a long time. If Dr. Cruz, we might need your assistance. So two of my consultants have said, bring a lawyer. Well, it'd be nice, but
Okay.
we don't really have the money for it.
I was just
Bill?
gonna ask a question, actually, Bill. I was gonna say, do they have a set criteria that if you don't meet this, this is for sure going to,
Oh, we're not going to take this laying down. And our whole thrust of John's, beginning I've been practicing, my presentation, and it's probably too long. It's still 18 minutes long. But I've been practicing, and John can probably attest to the fact that we're not apologizing for anything. We're not groveling. We're not saying, we're sorry, please, we won't do it again. That's not happening. It's just the facts, ma'am. This is what we're doing. This is how we see our organization, and the fact that no one's talked to us, no one's called, no one even knows what we do, and that they could advance a proposal like this is just ridiculous. In the meantime, while this was going on in secret, what were we doing? We were running these conferences every week. We ran our 50th anniversary in Las Vegas. In April, those of you who don't know, in April, we were re-credentialed in our CME credentialing for 5 years, which is the longest, the highest award that they will give. No, family practitioners don't get more than 5 years. We scored 99 out of 100, and I could have gotten the 100th point, but there was no difference in gain, and we have other things to do. And when our last live OMED, when they were there, those of you that were there, you remember they put us up where was that, in Baltimore? They put us up in a tiny room in the back, all the way up on the 3rd floor, and we had standing room and sitting room only. They twice had to move us because there was not enough room. We had out of 2,400 delegates, at one point we had 600 of them in our room. And remember, we're the little tiny fringe nobodies. So we're not groveling. We're not apologizing for anything. We're going to state our case and be that as may. We may get actually out of this. I'm hoping at the end of the day, when this is done, we will get those of you who don't know, last summer, we did apply for a name change from rheumatic diseases to integrative medicine. And I took the exact bylaws that they passed, that we wrote 3 years ago, that they passed for rheumatic diseases, changed that. All we did was change the where it said rheumatic diseases, we put in integrative medicine, and those are the exact same bylaws. All of a sudden they started nitpicking. There was a line in there, it said, our scope of practice. One of them was, it said new injection techniques, and there was a big discussion about the word new. I said, I'll take it out. So the question is, do the AO bylaws have a due process? Yeah, the answer is they'll tell you that there was no due process here. There was none, zero. We knew nothing about this. And again, all the while we're doing our work. And this is going on behind our backs. The really disappointing thing about this is, and this is a personal issue, is that the incoming president of the AOA, who's being inaugurated at this meeting, is Ernie Gelb. Ernie Gelb was my partner for 10 years. We actually shared call for 10 years. And at one point, where we lived was a flood zone. His office flooded out. He shared an office with me for a year and a half, and he states that he's recused himself, and so he's staying neutral in this. But it's a bit of a disappointment. So, okay. Brad says here he came across AOSRD at OMED talking about innovation and effective strategies in diagnosing and treating thyroid disease that's often autoimmune. So. Yeah. Okay, so there's my, in the chat there, DOC, you know how to find me, doctrbil9@gmail.com. If you can write a short testimonial, it would be great. I don't know if it'll do us any good. For all I know, this is already, it's already been decided, and I'm going to Chicago next week. I mean, I hate going there. It's hot. It's expensive. Even the Uber drivers are mean there. I'd rather do other things, but we've worked too long and hard, and this organization's been around for 50 years. And to just, in the middle of the night, try to throw us out is just not right. So, so if anybody can write a short testimonial, please do. If you don't, again, there's my email is doctrbil9@gmail.com, or you can send it to, if you go on our website, there's an email address there also. So, I don't want to belabor the point. Thank you for listening. I'm sorry that, this is an issue that we have to deal with, but we'll deal with it. So, John, you have anything else to add?
No, just if your talk in a week, when is it? This week or next week?
No, it's next Friday.
Okay, when you show up next Friday, if your talk persuades them to allow us the new charter, which is no different than our original charter, trying to advance medicine. If they allow that, we're going to be king of the hill of the osteopathic profession in integrative medicine, and we'll take it from there. And
Yeah,
if
well,
they choose,
I don't think they'll allow it there. They have their processes that they have to do. This is what Dr. Clower kept emphasizing. It's a process issue. It's not a
Well,
content issue. But
I did listen to what Dr. Clower said, and he says there's nothing in the laws that said they cannot give us the charter the same time you're there. If they can vote to decharter one in the same day, they could give us the new charter. If they do that, everything's beautiful. If not, then we'll play it as we need to.
yeah, we've been trying for almost 2 years now to shift to integrative medicine, because it gives us it would give us a stronger voice out in the real world. Again, a lot of you come by here. You've been here regulars, but I hear it over and over again. I didn't know you did this. It says rheumatic diseases. I'm not a rheumatologist, so we kind of have a one hand kind of tied behind our back. But we've had the the CME credits. We've had the impetus of the AOA, and I'm not going to go out. I'm not going to lay down and just let it happen. So so a week from Friday, I'll be in Chicago, arguing our case. Please wish me well. And if you have colleagues that know about our work, please contact them. And again, a short testimonial would be a help. Sylvia, if you got any
Yeah,
legal advice?
I was gonna ask, is it under the AOA? And I'll look at what
It's under the
how they-
AOA's it's under the AOA's House of Delegates.
House of Delegates.
It's under resolutions, and it's on page 187.
Okay. I'll just look and I'll take a look, see. But I think
Okay.
the 50 years is gonna be a big thing, is what other organization under the AOA has been running for 50 years.
Yeah, I have no idea. So probably the
Okay.
family practitioners and the internal medicine people, but I don't know about
Right,
anybody.
now we have a lawyer.
Yeah, okay, great.
Okay,
All
I'll
right,
take a look, in touch.
okay, I'll be in touch.
Well, we are talking about immune, how to enhance the immune system. I mean, so many lectures were on immune system, so many lectures. I mean, is it that the rheumatology, we are not doing anything? We have discussed about the immune polarization.
Okay, I know.
All of that. So,
Well, to the traditional, medical community, autoimmune disease and rheumatology is, biologics. We're going to give you a biologic. That's it. If you ask them about nutrition, they'll look at you like you have 4 heads. they'll tell you it doesn't matter. All of the things that we do, all of the little intricacies that we do, that they in their world, it's just a whole bunch of fluff. So, so I don't know how much time I'm going to have. I'm hoping to get 10 minutes. Right now I have my talks at 18. And I keep revising it. So, I'll try and get it recorded, to live there. I mean, I've been practicing, and anybody wants to hear it, I'll be more than happy to send it to you if you have nothing better to do. So,
You can send it to me, Bill.
okay. Well, John has one. Do you two talk or no?
I'm
Sometimes.
in Hawaii and he's in
Oh, okay.
West Virginia, and our
All
time
right.
zone
Okay.
is
All
screwed
right.
up.
I got all your letters, notes, and things from the AOA, and I'll send it all to Sylvia.
Yeah. Okay. All right. I'll send it to you too, Sylvia. I'll send you the latest one. So I keep
Okay.
changing it. So,
Okay, thank you.
okay. Thank you.
Thanks, Bill. Good luck.
Okay. Thank you. Okay. Well, that's next. Well, next week we have Dr. Harding. I'll still be here. It'll be after that. So,
Okay.
Thank you,
all right.
Bill.
okay.
Love to hear
Yeah.
your
And
response.
another suggestion so, with the way travel things are and whatnot. So, the talk in its final form will be put into letter form, and it will be entered into the record well before I get there, in case, there's a travel issue. So, okay. All
Yeah.
right. Thank you, everybody. Thank you for
Thank you.
coming, for being here. Thank you for being with us. This is kind of our core crew every week, and we'll carry on no matter what. But this, CME credit is they decertify us. We lose our CME privileges. So it's not a nothing. So they told me in the resolution, they say we can reapply, for something else, but who knows how long that'll take. You'll have to wait till their outfit next year. Do you have to? I don't know. I have no idea, and no one's giving me any answers. So the folks that I deal with at the AOA, in the CME department, the education department, and all. They had no idea about this either, and when I bring it up to them, they're as appalled as we are. We're there. We cause them. They tell me that we cause them the least amount of angst. All of our literature that we need to turn in for the programs are all dotted and crossed. They never have to send one back. And, John, we have to do this idiotic stuff with the lectures, this gap analysis thing. And, we make sure that it's always complete before they get it. It's always complete the first time. Well, it is what it is. I didn't ask for this fight, but we're going to see it through. So again, thank everybody. We're gonna say goodnight, and John, I'll be working again tonight. I'll have the version 4. So
See you all.
Sylvia, I'll put you on my list of who I'm sending everything to. Okay.
Okay, perfect. Okay.
Okay. Thank you so
you.
much.
Okay.
Thank you, everybody. Thank you for hanging in there. Okay, we'll see you next week.
All right.